Danielle already introduced who I was, and she talked a little about what I've been doing for the last 30 some years. I did go back to school in 2008 to 2010 and do my Doctor of Audiology program, but I've continued to be a clinical audiologist, and that's my love, meeting with patients every day and learning about what their needs are and finding creative solutions to help them. So let's just sort of jump in. I'm going to thank you for coming. I already said that. That's all about me. We already talked about that. What I want to talk about tonight is the relationship between hearing loss and the development of cognitive decline or dementia or Alzheimer's, all the different words you want to put to it. What we know is that there's a strong relationship. There's been some very interesting research come out in the last 4 years from the Lancet, which is the British Medical Journal, and from Johns Hopkins Hospital in the US. And I'm going to talk about those things tonight because there's a strong relationship. And the good thing is it's practical things that we can do to help reduce or slow down the processes of cognitive decline. One of the things that the article in the Lancet brought out in 2017 is that the symptoms of cognitive decline show up later in life, but the underlying brain pathology develops many years earlier. And that piece of research looked at all the potential modifiable risk factors that we're aware of. And what that showed is that it might, that with those modifiable risk factors, there might be up to 1/3 of the cases of dementia that could be slowed down or prevented, in fact. And here's what they look like. Early in life, education. So we know that early education, people who have more education early in life are less likely to develop cognitive decline. That's not something we can do a lot about now. That's when we were children. In midlife, the factors were hearing loss, hypertension or high blood pressure, and obesity. Later in life, smoking, social isolation, which we heard a lot about from Dr. Hand, depression, physical inactivity, which she also mentioned in her talk about social isolation, and diabetes. This is the little diagram that they put up about the potentially modifiable risk factors. About 65% of factors, I'm going to, if you see at the bottom of this, are things we can't do anything about. Those are our genetics. Those are the way we're built. There's the things we can't do anything about. But here it shows that early education, less education, it accounts for about 8% of the modifiable risk factors. Hearing loss at 9%, hypertension at 2%, obesity at 1%. Late in life, smoking is 5%, depression 4%, physical inactivity 3%, social isolation 2%, and diabetes 1%. So there are about 35% of the things that we know are related to cognitive decline are things that we can potentially do something about. This is just a blow up of that, so you can see that a little bit better. I broke it down here. Hearing loss accounts for about 9% of those factors, smoking 5%, depression 4%, physical inactivity 3%, and social isolation 2%. Those are the major ones. That accounts for about 23% of the modifiable risk factors that we have. Back in 1980s or late 70s, when I was in school in learning to be an audiologist, we knew back then that individuals with hearing loss suffered from social isolation. They suffered from depression, paranoia, and reduced physical activity. We knew those things, but we really didn't have a lot of other research to point us on where those things were coming from. What we know now is that of hearing loss, which accounts for about 9% of those modifiable risk factors, but we know that hearing loss leads to depression and social isolation and physical inactivity. That's another 19%. So it means that almost 18% of dementia cases could be eliminated, reduced, or delayed significantly by treating hearing loss early in midlife. That means that treating even mild hearing loss is now strongly indicated. What that means is, what we're telling family physicians out there is when people hit 50, it's time to send them to have a hearing assessment to find out where their hearing is. If it's normal, that's great. We've got a baseline to work with. If there's hearing loss beginning to show up, early treatment helps, gives us much better long-term outcomes in terms of our hearing and slowing down the effects of cognitive decline. All human brains become smaller as we get older. It's accelerated in people with hearing loss. We know that from research and studies looking at people's brains. Untreated hearing loss may result in serious long-term consequences to healthy brain function. That shows up in the research from John Hopkins Medicine. One of the things that we know, we think, well, why is this? Why is it that hearing loss affects our brain? Why is it that it leads to cognitive decline? The biggest issue, or one of them, the biggest ones, is cognitive overload. And what that means is when we begin to have trouble with our hearing, understanding language becomes difficult. People speak and we hear them, but we're not always sure what they've said. So our brain has to work extra hard to figure things out. So we're looking at contextual cues. What did we just finish talking about? What are we likely to talk about next? And then making good guesses about that. But it also means things of, is it a sunny or a cloudy day? Did a dog just walk past us? Did someone just spill their coffee? All of those things, those extraneous things, help to give us cues to make good guesses when we haven't heard the words clearly. But that uses a lot of cognitive resources. So our brain gets overloaded trying to figure out what people are saying. That cognitive overload starts to use up resources that used to be used for other things, and particularly having to do with memory. So people will come away from a social engagement saying, boy, I'm exhausted from that. It was really hard work just to be there and to listen and understand what people are saying. But over time, that cognitive overload starts to rewire our brain. And areas that used to be used for other things are now being used to help with language. And so that leads to often trouble with short-term memory issues. The other thing that happens is social isolation. And this ties in very directly with what Dr. Hand was saying. When we don't hear well, we begin to slowly drop out of doing things, not because we want to, but because, well, you know, when I go to play bridge, I really can't hear what the other people are bidding. And so, I'm going to stop going to play bridge, or I don't go to church anymore because I can't hear what the priest or the minister is saying. I don't really like to go to family gatherings because when I go there, I can't follow what's going on. So I just sit in a chair and nobody talks to me because I can't follow. Those are sad things, but they happen because of not hearing well. People begin to drop out of social interactions, which is all part of social isolation. And it's a really significant factor, and something that, again, something we can do something about to keep people engaged. We know from research that people with untreated hearing loss are up to 5 times more likely to develop dementia. That's a big amount. That's a big factor. And if we can improve that by treating people's hearing loss with appropriate hearing devices or other rehabilitative methods, then that's a really good thing. 5 times is a big difference. And if we can improve that, it's one thing that's going to make a big difference in people's lives. What it means is that people who are 50 plus should have their hearing checked regularly. We want to be on top of it. Or starting early treatment is the best thing we can do to improve cognitive, to improve the chances of reducing the risks of cognitive decline. You know, people often say, well, goodness, I'm 85 years old. Should I do something about my hearing now? And of course, the answer is yes. It's sort of like the question about when's the best time to plant a tree. Well, 20 years ago was the best time, but the next best time is today. It's never too late. And in fact, there's some interesting research happening at the University of Melbourne right now. And their preliminary research is suggesting that not only does treating hearing loss slow down the progression of cognitive decline, but it actually can reverse it. And they're showing some improvement in cognitive performance after people have been treated with appropriate hearing devices and are using them on a regular basis. The good thing is about getting your hearing assessed is it's easy. There's nothing difficult about a hearing test. It doesn't cost anything to have a hearing test done. There's no commitment about it, and it'll help you to understand where you're at this moment. And it gives us a baseline to work with for the future so that we can monitor at appropriate times so that when the right time comes to do something about hearing loss, we can be on top of that. There's something else I was leading to there, and it just slipped out of my mind right now. I guess one of the things I was saying, as part of our assessments at True Hearing Health, we provide a cognitive screening at our office. So a little computerized game, really, that you play. We're the only place in Canada to have this technology. It's an FDA-approved cognitive screening tool. You play a little game on a computer, and it helps us to know about your short-term memory, executive function, your processing speed, reaction time, and your visual spatial skills. It takes about 10 minutes, and it's not something that's administered by a person. It's administered by the computer, so it's always done the same. The retest reliability is excellent with it, and it gives us, again, a window of where people are at cognitively. That helps us. If we see significant issues there, then of course we're going to refer back to your family doctor and say it would be appropriate to do more extensive cognitive testing for this person. But the other thing that it helps me with is developing an appropriate hearing treatment plan in the way that we set the hearing devices based on where the challenges are with their cognitive function at that time. So it's an important piece of the pie that we incorporate into our processes at True Hearing Health. Let me just move down here one page. That's our phone number, but remember it's 1135 Adelaide Street North. So we're just north of Huron Street on Adelaide, on the west side of Adelaide Street. I'm open to any questions that anybody might have. It's something that I'm passionate about. I've been doing this for, well, too many years. My wife keeps saying, don't say how many years you've been doing it. They're going to think you're an old man who doesn't know anything. But I've been doing this for 35 years or so. So I'm passionate about helping people with their hearing, and particularly in the last few years when we've really seen how important hearing health is to our cognitive health as well. It's just something that I'm passionate about, and I love to help people and love to interact with people all the time. So I'm open to questions.
Thanks, Brian.
I'll stop sharing my screen here. So
sure, and I'll just ask the questions here. So the first question is, what is the cost of hearing aids? Typically, I guess.
That's a great question. And the short answer is hearing aids can be a big investment, but they can vary. Typically, we try to work with people and their budgets. And my advice to people always is you want to use the best technology that's affordable to you. There's no doubt that the better technology works better, but that doesn't mean that even the more basic technology isn't better than not doing something at all. So that's sort of an evasive answer, but just to give you some ideas, the government of Ontario provides a grant. It's called the Assisted Devices Program. That grant is $500 per year, so it's $1,000. Everybody in the province gets that. As long as you have a health card in Ontario, you're eligible for that grant, whether you're a day old or whether you're 120. And after that grant, prices can vary from about $3,000 for a pair of hearing devices up to about $7,000 a pair. So there's a broad range, and we work carefully with our patients to make sure that we're using the best device that fits with their budgets.
Okay. Any suggestions for the people in, oh, sorry, the chat is moving quickly. Any suggestions for the people in our lives that have hearing aids but claim that they do not work for them, even after multiple adjustments, models, etc.? Yeah,
I guess my answer to that is that models don't really mean very much. There are only 6 manufacturers of hearing aids in the world. They all have sub-brands under them, but they all are good. There's no one brand that has some big secret over somebody else. And I know, if you're on Facebook or on the internet, you're seeing, oh, the latest new device from Germany is now available in Canada. There's nothing available somewhere else in the world that we don't have available here. There's nothing that we have that the rest of the world doesn't have. And there's no new big secret. The technology is all good. The secret to doing well with hearing devices is not the choice of manufacturer. It's having the proper assessment to begin with so that there are accurate results to use to set the devices, and then knowing how to set them properly based on that individual's needs, and then teaching them how to use them properly and what to expect. Very often, the reason people don't do well is that their expectations have not been set properly at the beginning, nor has there been an appropriate treatment plan gone along with the devices to move them through the process. Hearing aids, it's not like buying a toaster. It's not something you buy and you plug in and it does its job. Hearing devices, it takes time to acclimatize your brain to getting used. Things we pay particular attention to is making sure people understand what to expect, and we develop a treatment plan with them to develop that their brain capacity to hear again. And it takes time, and it takes patience, and it takes understanding, and it takes good coaching. And so I think that's the biggest factor is the coaching that goes along with it, not the device. Very rarely is it the device.
Okay. Another question here. What about tinnitus for hearing loss? Any treatment available that actually has some success that you know of?
Okay, that's a great question. And the short answer to that is there's no magic cure to tinnitus. And again, if people have been searching for this on the internet, they'll see a million treatments for tinnitus. None of those things do anything on their own, but a number of them can be useful depending on the situation. There are many things that we know can cause tinnitus. 90% of people with tinnitus have an underlying hearing loss, and the tinnitus is there because of damage to the inner part of the ear. But other things can modify it or can cause it. Things like high blood pressure can cause tinnitus. So if we can treat the high blood pressure effectively, that can reduce the tinnitus. So some of those herbs and spices that you might see on the internet that were magically cured somebody's tinnitus may be helpful if they help to reduce high blood pressure, or they relax you. Physical tension in your neck or temporomandibular joint, if you grind your teeth at night, those can be factors that affect tinnitus as well. If you've had a whiplash injury or concussion, head injury and neck injuries can be factors with that. So treating those things can help with the tinnitus. But in terms of some magic pill that makes tinnitus go away, that doesn't exist. However, the best single method we have of helping with tinnitus is to treat the underlying hearing loss that exists 90% of the time. So treating the hearing loss will for most people, makes a significant improvement in tinnitus. And ultimately, what we want to do with tinnitus is teach people to ignore it. Just like people who live beside railroad tracks don't notice trains driving by anymore. It's not because they don't hear them. It's because their brain has learned to say, that's a meaningless piece of information that I don't need to pay any attention to. And that's what we want to teach people to do with their tinnitus, is to have their brain treated as a meaningless piece of background information that doesn't mean anything. That again takes a proper complete assessment and looking at all the possible risk factors associated with tinnitus, and then developing an appropriate treatment plan to help people just attain that goal. So can it be helped? Absolutely. Is there a magic pill? No, but that's something that I've spent a lot of time helping people with, is with tinnitus.
Okay.
Oh, and just by the way, you can say tinnitus or tinnitus. Either way
I was
is
going to say, I think I said it wrong, but.
No, but there's no right and wrong. In fact,
Okay.
I purposely switch back and forth so I don't sort of show preference to one or the other.
Fair enough. Okay. The next question is, how is True Hearing Health different from other hearing organizations?
Well, partly my experience is one of the things. I've been doing this for a long, long time. So I'm careful about doing a very thorough hearing assessment at the beginning, understanding people's specific situations where they're having trouble. I spend a lot of time with my history taking, finding out what challenges are you having? Is it hearing the TV? Is it hearing your family? Is it hearing your spouse? Is it hearing at church? Is it hearing when you go to a meeting? We're looking at all the things that are important to that person, and then developing a treatment plan that will help with their specific needs. So finding out people's needs is important, doing a proper assessment. And one of the nice things about a brand new office is all our equipment is right up to date. It's high tech. And one of the things that we do that nobody else does is the cognitive screening, which helps me when I'm developing the right treatment plan, both in terms of what's appropriate in terms of coaching and helping the patient learning how to use their devices, but also how we actually set the device can be modified by what those results are. So brain science, I guess, is the one thing that comes into play, that we pay attention to what's going on with their cognitive skills.
Very good. Okay, the next question is, my dad is in early dementia and won't wear his hearing aid. Should we
Mhm.
encourage him to wear it?
Short answer is yes. Absolutely, you should encourage it. I know that can be a challenge, but what my goal with patients is that they wear them from the time they get up in the morning until the time they go to bed at night, with two exceptions. One is don't jump in the pool with it, with your hearing devices on, and the other is if you're going to be doing some noisy thing, if you're going outside to cut down a tree with a chainsaw, some place where you should be using hearing protection, we don't want your hearing aids on. But the rest of the time, having them on is important. We want to get to the point where it sounds normal with them on and really dull when you take them off, instead of sounding normal without them and like something extra when you put them on. So yes, absolutely encourage him to use them.
Okay. Does having dementia increase progression of hearing loss?
There's no evidence of that. In fact, the evidence would sort of show the other way around, although you can't show cause, but we certainly know that the two are related to each other. But the way that the research is tending to look is that hearing loss or untreated hearing loss is a factor in the development of dementia, as opposed to the other way around. I guess where dementia could be seen as an issue with hearing loss is, um, and it can be so confounding. Did the person not understand the question because of the dementia, or did they not hear the question because of their hearing loss? So it can be very confusing. In fact, that's one of the things that I'm really trying the message to get out to people who are doing dementia or cognitive testing is, let's at least make sure that the person can hear before you're asking them questions to determine whether they're cognitively intact. Want to make sure that they hear the question in the first place. So having a hearing assessment before doing a cognitive assessment is extremely important.
And that kind of ties in here. Are all hearing assessments free everywhere, or is it just specific locations?
Pretty much everywhere it's free. Yeah.
Great. You sort of touched on this already. What if the person with dementia doesn't want to wear hearing aids, and obviously just encouraging them to?
Encouraging is all we can do. It's one of those things, nobody can force somebody to wear something, but trying to help them understand why it's important and how it not only helps them, but it helps their family. When communication breaks down, not only is it difficult for the person who's not hearing well, it's really frustrating for family members who are trying to communicate. I had a lady in talking to me today. She says, I feel badly because I have to yell at my husband, but he can't hear unless I raise my voice. And I feel like I'm yelling at him. And that makes me feel bad because I don't want to yell at him. And yet he can't hear and he won't do anything about it. Now it was I was seeing her, not her husband. But it's difficult for everybody when communication breaks down. So anything we can do to improve communication helps everybody, both the recipient and the giver of the information.
So this just says, this has been fantastic. Do you have any strategies for those with dementia taking hearing aids out and then stashing them, not able to be found, which can be very devastating to families given the cost to replace? And I know this is something that lots of people deal with. So I don't know if we have any specific suggestions, but
It is challenging. There's no doubt. And I've had patients who've put their hearing aids in with their false teeth in a cup of water at night, and not necessarily because they're meaning to, but they mixed it up. At night, I put my dentures in a cup of water and they put their hearing aids in there as well. So depending on their living arrangements, having someone else help them with what to do with their devices at night. Now, one of the nice things about everything that we're using at our office now are all rechargeable now. So at night when they come off, they're put in the charger. So it's almost a new thing that we can teach people. You take them out of your ears and they go in the charger. So it's like putting your teeth in a cup of water at night. It's a place that they go, and teaching people how to do that helps them to get them in the right place overnight. But people stash them away. They think they're, I've had people say, or not say, but families say, they're worried about them being stolen, so they tuck them away somewhere and then we can't find them. Things like that happen. And it's just one of those things. We have to do our best to try to figure out ways, either with if they have caregivers, to have somebody help them with that so that they're put away in a safe place when they're not being used.
Mhm. What should we know about the person doing the testing, and how would we know if they're qualified properly?
Okay, that's a good question, and it can be a fuzzy issue in Ontario. In Ontario, the act of prescribing a hearing device it's a licensed act in Ontario. Only audiologists and physicians have that licensed act. However, the government sort of bypassed that legislation through their assistive devices program, where they allowed a doctor signing that ADP form to act as the prescriber, even though they don't know anything about hearing loss, so that people who are called a hearing instrument specialist. That's a two-year college program. And that's designed to have people who know how to fit hearing aids and how to fix, do cleaning and repairs of hearing aids. But it's allowed them to step into the role of actually choosing the right device and just having the doctor sign for it, even though the doctor doesn't know what they're signing really with that form. So unfortunately, the assistive devices program has sort of circumvented the legislation that was set down, making that a licensed act. So what you want to look for is somebody with experience, someone who's an audiologist. An audiologist has a minimum of an honors undergraduate science degree, and then a three-year master's after that. And many of the audiologists in London now have a Doctor of Audiology as well. And so those are the people you want to seek out, who really understand what they're doing and what and all the intricacies of it, not just picking a hearing aid and selling a hearing aid. That's not what helping people with hearing loss is about. So you want to look for an experienced audiologist and someone who's trustworthy, someone who when you speak to them, has answers to your questions and doesn't hide from questions.
Very good. This is a specific question for you. Can I come see you if I have purchased hearing aids elsewhere?
Yes, you can. Absolutely. And I'm happy to see people in that regard, because I often run into that, where people have a device that may or may not have been the best choice for them, but I'll work hard with that device to make it the most suitable for their hearing loss that we can. So I'm happy to see people who've gotten them in other places. Yes, absolutely.
Wonderful. This is, yeah. So someone in the audience has tinnitus and they just got hearing aids 2 weeks ago.
Mhm.
How long do you think it will take to adjust or get used to the hearing aids?
People are again very different in how they react to that. Most people within 2 weeks have come a long way at getting used to the sound of what the hearing aids sound like, and their brain starts to adapt to that. But it can take up to several months to adapt to that. And I'm not sure from the question whether it was getting used to the sound of the hearing aids, or whether it's helping him at all with his tinnitus, or his or her tinnitus.
It doesn't say, it just says how long will it take to get used to it. So I'm
Yeah.
assuming it's the hearing aids, but
That's one of the things at True Hearing Health, where we set out a defined treatment plan where there's follow-up visits
mhm,
along the way, so we can find out how people are doing, make adjustments along that way, continue to encourage and counsel them on what to expect and how to adapt to things. So it's not a here you go, see if you
right.
have a problem. We plan to see people back to work through that adaptation time.
Great. And then there's one final question here that says, can hearing aids be recycled? And also, how much do hearing aids help with the central auditory?
Okay, again, two good questions. We do recycle old hearing aids, but not here, but we collect them for agencies that will use what they can of them to use in third world countries. So we do collect them, and we provide them to some of the companies that do that kind of work. In fact, over the years, I've been involved in 3 different missions, two to Bethlehem and one to Istanbul, where we worked with children there that didn't have access to devices, and we fit them with some refurbished, but in some older new products and that kind of thing that hearing aid manufacturers donated. So yes, they can be reused. And I've forgotten the second part of that question. Recycled.
Yeah, how much do hearing aids help with the central auditory?
Okay. Central auditory processing is our hearing system. Our auditory process starts at our ear. but it works all the way up through the cochlea, the brainstem, up to our cognition, to our cerebral cortex. And anywhere along that process, things can interfere with how we process language. Hearing aids allow us to give the best speech signal possible to that system. They don't particularly treat those internal connections, but we know that by giving the best speech signal along that system, it will help to maintain its integrity. That's one of the things that happens as we start to get a degraded speech signal from not hearing all the sounds. Our system doesn't work nearly as well. It's trying to adapt and change to that. But what's happening in our memory, short-term memory, is we have it's like a recognition system there that says, okay, that package of sounds, that's the word health. But if health is all mixed up and you only hear health, then your brain doesn't know what that word is. And so it's scrambling to try to figure it out. So our whole auditory process can be delayed with that. But hearing aids are not necessarily a treatment for if they're specifically asking for central auditory processing skills, which is something that we work a lot with children. I don't anymore. I don't work with auditory processing skills. But it's not a direct treatment for that, unless there's a peripheral hearing loss that is impacting on that.
Fair enough. And I think a good final question, how soon can someone get in to see you?
That's a great question. One of my goals has always been to be able to see people within 2 weeks, and we're pretty much keeping to that right now. So I'm happy to see people, but usually within 2 weeks is our goal. Unless, and let me just say this, if it's a sudden hearing loss, and this happens sometimes where people wake up one morning and say, hey, I can't hear out of my right ear. It's gone. Those people we will see that day. So if you call up or if you go to see your family doctor and you've had a sudden hearing loss, we'll make sure that we see those things immediately, because sometimes that type of loss can be, there's a better chance of recovery if there's very early treatment. So we would see what the assessment showed, and then if in fact it was a true sensorineural sudden hearing loss, we have a pipeline to get you into see an ENT within a day or two.
Very good. I know that was a little bit more than 10 minutes of questions, Brian,
That's
but thank you very
fine. I didn't
much.
talk for my full 20, so that's good.
That was perfect. Yeah, it worked out.
happy.
And just a compliment, says thanks for the great presentation. And Carrie, I don't know if you're still there, but I think she might have left, but there was another question for her. So whoever had that question, if you just want to send it forward to me after the session is over, I will make sure to ask her. And thank you very much, Brian, for being with us tonight and sharing your knowledge. And yeah, that was wonderful.
My
Learned
pleasure.
a lot.
My pleasure. Thank you.
Thank you.